Medical disclaimer. This video is produced for entertainment purposes only. I am a retired MD and PhD in biochemistry with specialization in orthopedic surgery, spine surgery, chronic pain management, and medical aesthetics. I am not currently practicing medicine, and nothing in this series constitutes medical advice, diagnosis, or treatment. All analysis presented is speculative, based solely on publicly available observations and public rumors. I want to begin this episode by acknowledging something directly. What I am about to discuss, reports of bladder incontinence and rumors of bowel incontinence, is deeply sensitive. It is also, from a clinical perspective, the most diagnostically significant information we have examined in this entire series, because these two findings, when combined with everything we have already established, do not merely add to the picture, they reorganize it. They change the diagnostic hierarchy. And as a retired orthopedic and spine surgeon, I can tell you, they point towards something very specific. In neurology, there is a condition called normal pressure hydrocephalus, NPH. It was first described by Dr. Salomon Hakim and Dr. Raymond Adams in 1965, and it carries a diagnostic signature so specific that it has its own name, Hakim's triad. The three components of Hakim's triad are, number 1, gait disturbance, a shuffling, wide-based magnetic gait as if the feet are glued to the floor. Number 2, cognitive impairment, executive dysfunction, slowed processing, memory difficulty, and frontal disinhibition. Number 3, urinary incontinence, initially urgency incontinence, the sudden, uncontrollable urge to void, progressing to frank loss of bladder control. Now, let us pause here. Because if you have been watching this series from episode 1, you will recognize that every single element of Hakim's triad is now present. Every single element of Hakim's triad, the gait, the cognition, and now the bladder, is present in this observable clinical picture. NPH occurs when cerebrospinal fluid, the clear fluid that cushions the brain, accumulates in the ventricles. Not because too much is being produced, but because its resorption is impaired. The ventricles enlarge under this pressure. They press outward against the surrounding brain tissue. The regions compressed first are critically important. The motor fibers controlling the legs run along the inner surface, close to the ventricles, and are compressed early. The frontal lobes, governing executive function, impulse control, and cognitive flexibility, are compressed next, producing the cognitive and behavioral changes. And the pathways controlling bladder urgency, which travel through the paraventricular white matter, are also compressed, producing the urinary incontinence. This is not a coincidence. This is pathophysiology. The anatomy explains exactly why these three symptoms occur together, in this order, as a coherent clinical syndrome. Urinary incontinence is a well-established feature of NPH. Bowel incontinence is less common in pure NPH. Its presence, if accurate, is clinically significant in two directions. The first possibility, it indicates more advanced disease. The neurological damage has extended beyond the circuits that control bladder urgency into regions governing lower bowel sphincter control. This implies a more severe or further progressed process than early or moderate NPH typically produces. The second possibility, and this is where my background as a spine surgeon speaks directly, is a spinal cord contribution, specifically cauda equina compromise. The cauda equina is the bundle of nerve roots at the base of the spinal cord. The sacral nerve roots, S2, S3, and S4, are responsible for bladder and bowel sphincter control. Compression of the cauda equina, from severe lumbar spinal stenosis or a large central disc herniation, produces what we call cauda equina syndrome. In a patient of advanced age, with the body habitus we have described, severe lumbar spinal stenosis is not merely possible, it is highly probable. The combination of urinary and bowel incontinence demands that a spine surgeon's differential be placed alongside the neurologist's. Normal pressure hydrocephalus is one of the very few causes of dementia that is potentially reversible. Here I must tell you something that makes NPH, if confirmed, one of the most urgent diagnoses in this entire differential. A neurosurgical procedure called ventriculoperitoneal shunting, draining the excess fluid into the abdominal cavity, can dramatically improve or even restore function. In the right candidate, after shunting, the gait normalizes, the cognition improves, the incontinence resolves. The word potentially carries enormous weight here, because the outcome of shunting depends heavily on how much coexisting pathology is present. If NPH exists layered on top of established Alzheimer's pathology and significant vascular disease, as the evidence suggests, then shunting addresses the hydrocephalic component only. It leaves the underlying neurodegenerative disease completely untouched. The cognitive gains are real but partial. and the window for maximum benefit narrows each month. With this new information incorporated, the updated diagnostic hierarchy now reads as follows. Primary diagnosis, leading the differential, normal pressure hydrocephalus, elegantly unifying the gait, cognition, and bladder symptoms into a single treatable cause. Co-primary consideration, cauda equina syndrome secondary to lumbar spinal stenosis, explaining the bowel incontinence and contributing to the gait disturbance. Underlying co-pathology, mixed Alzheimer's and vascular dementia, the neurodegenerative substrate on which the NPH is superimposed. Systemic driver, severe obstructive sleep apnea. Cardiovascular, hypertensive heart disease with probable atrial fibrillation, the upstream source of injury. I want to be direct about what the bowel incontinence finding means in terms of functional severity. Fecal incontinence is not an early finding in any of these conditions. It is not a mild finding. In geriatric medicine, it is a marker of advanced neurological or spinal compromise. It is one of the functional milestones used to stage severity of illness, and it consistently correlates with significant impairment in activities of daily living. A person experiencing both is by clinical definition in moderate to advanced neurological decline. The most primitive, reflexive functions of the nervous system are failing. Executive functions for high-stakes decision-making, assessment, strategy, impulse regulation are operating on a neurological substrate that is measurably failing. The question this episode leaves us with is not medical, it is civic. What does this mean for the governance of the most powerful nation on earth? Episode 7 assembles everything: the full synthesis, the prognosis, the timeline, and the guide for what every citizen should be watching for. Learn more about this and other stories at unbedsidemanners.com. Join us for the series conclusion.